Dr. Yang, please.
Okay. Good morning, everyone. I'm fourth-year resident Yang Junnan. And thank you for joining us in the PRS resident webinar series. We are very honored to have Professor Rei Ogawa to be our invited speaker of the educational lecture today. And Dr. Tai Jiaxuan will be our moderator. Please allow me to give a brief introduction about Professor Koen Medical School in Tokyo, Japan, with a position of professor and chief at the Department of Plastic, Reconstructive, and Aesthetic Surgery. He was graduated from Graduate School of Medicine, Nippon Medical School in 2004, and he joined the Tissue Engineering and Wound Healing Laboratory in Brigham and Women's Hospital, Harvard Medical School in Boston, where he worked between 2007 and 2009 as a research fellow. Since then, he has focused his studies on the mechanobiology and its applications to tissue engineering, wound healing and scarring, and anti-aging medicine. And now he's a world leader in this area. So let us welcome Professor Rei Ogawa. Professor, please.
Yes, thank you so much for your kind introduction. So I am very honored to be here. So today, especially, I'd like to talk about the basic of local flap. So I'd like to share my slides. So you can see my slides. Is it okay?
Yes, we can see it.
Okay. Thank you so much. So I'd like to talk about local flaps. So please remember, at least there are three types of basic local flaps. One is advancement flap. Second one is rotation flap. Three is transposition flap. Of course, there are other type of flaps, but this is a classification by movement of flap. So at first, I'd like to talk about advancement flap. So this is surgery using pig skin. So reconstructed area is made and a triangular shape is designed adjacent to the recipient site. And always the important things is before dermal suture, the subcutaneous tissue should be sutured and tension should be released. Important things is tension of dermis should be released because hypertrophic scars, keloids, scar contracture are developed on the dermis. So before dermal suture, we have to suture subcutaneous tissue. And this is VY flap. In this case, we use skin suture glue. Sorry. And this is case. So for example, this is VCC. So remove with margin. And this line should be on the nasolabial line. And the flap is little by little extended. And subcutaneous tissue is sutured. Then we confirm the tension is released. Then we have to do dermal suture and superficial sutures. And this patient had a hypertension, so inflammation continued a little bit, but 6 months later, 1 year later, 2 years later, the inflammation gone. So actually, in case of tip of nose, you think the much more larger flap is better, but such kind of small flap would be fine sometimes, immediately after surgery, and 1 year after surgery, 2 years after surgery. And the contracture of red lip. So in this case, the triangle shape is designed on the white lip and come down and closed. And this line, Cupid bow, is reconstructed 1 year after surgery. And another type, the skin is relaxed. There are a little bit, the scar is not so wide. So in this case, just cut this one. And this side is not cut. So just advanced and the Y shape is made, and 6 months after surgery. So sometimes this area, the VY flap is very important, but we consider just this side is cut or this triangular, circular island flap, or this type is not island flap, pedicled flap, but sometimes island flap. This case is island flap pattern. Okay, so this type is double VY flap and cutaneous on the mucous side. So this is recipient side, and after resection of tumor, the VY flap is made on the skin side and the mucous side inside, and make this border line. Immediately after surgery, the mucous side, the mucous flap advanced here, and skin flaps advanced here, and 1 year after surgery. This is similar things. So remove with margin. And once we used artificial dermis, and we checked the tumor is completely dissected, then we reconstruct. So we have to mark the borderline of red lip and white lip, this one, and VY flap. In case of lower jaw, the flap should be designed like this and advance towards the lower lip. Okay, and the mucous side is also coming from inside and suture with this line. So this borderline should be marked. This is very important, and flap should be completely matched. And immediately after surgery, and 1 year after surgery. If this patient complain about this scar, next step is maybe W-plasty, or if scar is minor, maybe fractional laser we do. But many older patients don't want to improve more, so it's no problem. Okay, this case, in case of upper lip, the bilateral side is relaxed, many cases. So central part, remove everything, and VY flap is designed bilaterally and advanced. And this is 6 months after surgery. So actually, in this case, the flap has a hair, so hairy flap. So actually, the scar is hide, and the natural reconstruction was performed. Okay, this type is not VY flap, YV flap. YV flap means cut like Y and make V shape. Okay, so this is meibomian carcinoma. So at first, remove everything and suture directly, and contracture exists. So in this case, cut like Y, okay? Y shape we cut. And this flap is inserted to this area. So immediately after surgery, shape becomes V. So YV flap, please remember. So this is 1 year after surgery. So always the advancement flap, in case of advancement flap, we have to think about how to decide the length. So actually, area of subcutaneous tissue pedicle is determined by the length. So if we design longer, cutaneous pedicle, the supplying blood flow, we can remain a lot. But in this case, the pedicle should be small. So it is difficult to extend this area, just white area can be extended here. So it is difficult to cover, but longer we design, too much length we don't need, of course. But so always please think about maybe two times larger than 1 to 2 times larger than recipient site length would be fine, I think. So in emergency case, if it doesn't reach to this side, so another side we can design, but result is not so good, but such kind of rescue can be performed. So actually W-plasty is an advancement flap you have to realize. So this is isosceles triangle W-plasty. So this is old scar. So zigzag line we cut, and this side is advanced and make zigzag line. So this is actually a kind of advancement flap, bilateral advancement flap. So in this case, the W-plasty has an accordion effect and the block line effect. So prevention of dehiscence. So the scar becomes flat and less visible compared to preoperative state. This is a scaling triangle W-plasty. This is not isosceles triangle because this line should be matched to the crease, forehead crease. This area, the muscle line is straight, so we don't put Z. So this area we can suture straight, and the forehead, the zigzag line, and the zigzag line, this line should be matched, aligned to the forehead crease. So subcutaneous tissue is sutured, and then almost the wound is attached. Then we start dermal suture and superficial suture we do. And immediately after surgery and 1 year after surgery. So this is scar, but not so less visible compared to preoperative state. Okay. So actually Z-plasty is transposition flap. I will talk later. But in case of forehead, Z-plasty is another choice for hairy lesion because this outstanding scar will be completely covered by Z-plasty. So Z-plasty is much more dynamic to move hairy lesion. So sometimes we do Z-plasty. So next one, I'd like to talk about rotation flap. This is also very important flap. So remove the scar, and of course, in case of scalp, we have to design larger flap to cover. So largely we cut round shape adjacent to the recipient side and elevate under the galea, and the galeal flap is moved and sutured. So also galea should be sutured, sometimes 2-0 PDS or 1-0 PDS. Then the tension is released. We moved to suture subcutaneous tissue using 3-0 PDS. Then little by little, we do dermal suture and superficial sutures. This is 1 year after surgery. So this type of flap has a name, cheek rotation flap, as you know. The skin cancer is removed and the design like this. And the important things is intraoperatively, little by little, we undermine the flap and try to move to the recipient side. And when we judge, it's enough to move, and this side reach to the recipient side, we stop to undermine. It is very safe procedure. So little by little, we try to move and undermine and move, try to move. So little by little, we advance the undermining of flap. So this is immediately after surgery. And 1 year after surgery, there are no contracture, and there less outstanding scar is performed. And this is small rotation flap. So skin is relaxed. We don't need to design cheek rotation flap. Small rotation flap would be fine, many cases. So 6 months after surgery, almost there are no bumpy surface, and a little bit scar is shiny, but acceptable results. Already 3 months after surgery, inflammation has already gone. So in case of older patients, the inflammation coming down faster. So the local flap technique is very good for older patients. So this is keloid. So we perform post-operative radiotherapy, but remove everything, and the rotation flap is designed. So maybe you want to design VY flap. Of course, it is another choice, but I will talk later. But skin pedicle, if we can keep, it is clearly, it has an advantage because skin pedicle can release tension effectively. So if we cut circular shape, it is difficult to release tension because circular shape scar will be produced after operation. So skin pedicled flap is clearly better to release tension in the meaning of releasing tension. So we stop, like VY flap, we start to design like VY flap, but we stop here. And if, just in case, if the flap doesn't reach, we cut like VY. So skin pedicle, as much as we can, we have to keep. So smaller rotation flap has another name because this is Hatchet flap. This is small rotation flap. So it becomes smaller. The shape, flap shape looks like axe, the hatchet. So such kind of flaps, the Hatchet flap would be fine. And 1 year after surgery. So this is also Hatchet flap. So skin pedicle is very important to keep remain. 1 year after surgery. This is keloid, so the post-operative radiotherapy was performed. So this is just skin cancer resection. So this is combination of Hatchet and VY flap. So upper part is reconstructed by Hatchet flap, and this lower part is reconstructed by VY. So important things is always in case of local flap surgery, the largely cut and softly suture. It is important. So if you design just one side, the tension becomes higher. So always softly construct, softly we have to suture. It is very important to decrease inflammation after surgery. So softly suture, and immediately after surgery, the wound becomes larger. But 1 year after surgery, the reconstruction, the shape, nose shape is symmetrical, and there are no contracture, and scar, the inflammation has already gone. So largely cut, softly suture, please remember. Okay, so young female, it is difficult because after surgery, inflammation tends to increase because estrogen. Estrogen has a vasodilation effect. Blood vessel, blood flow increase. So in case of female, carefully we have to do surgery. But such kind of skin cancer reconstruction, so cheek rotation flap plus Hatchet flap we designed. So even if the wound becomes larger, the softly suture we have to try. So immediately after surgery, it becomes large, but 1 year after surgery, almost the around here, no problem, I think. But still, this area is bulky, so I'm now planning to reconstruct here by local anesthesia operation. So this is another case, Hatchet flap. And this is keloid. So post-op radiotherapy we perform. So this is also bilateral scapular keloid. So reconstructed and post-operative radiotherapy. So maybe in this case, we can design the flap, this area, but in this case, the skin is relaxed under the keloid. So we design this side. So this is pressure ulcer. So after debridement, we design skin pedicle flap, and this lesion is cut. And this is 3 months after surgery. So in case of rotation flap, always we have to think how to decide the size. But please try to, at first, please try to pinch by your finger. And you can design, but the ideal length is 1 to 2 times larger than recipient site, I think. So in this case, area of subcutaneous pedicle is determined by the length. It is similar to BY, but in case of rotation flap, skin pedicle can be remained. So blood flow, especially venous drainage, is very strong from skin pedicle. So largely we can undermine the flap. It is quite safe, but of course, we can stop if this area reaches to the opposite side of the recipient side, we should stop. Because if so, the quite safe local flap can be harvested, okay? So always intraoperatively, please try to move to the recipient side, and it is still tension exists. We go back and a little bit go ahead, remaining undermining, and again we try to move to the recipient side. Little by little, we have to do. And please consider which side is better to design. So maybe always you have to try to pinch, and you have to check. But actually, the role of the flap is assistance of direct suture. Please remember. So in this case, left side, recipient side, if you try to close directly, this direction you close, of course you close. So this side you should, to assist direct closure, this side you have to design. But in this case, so you have to close this side, so it is very difficult to reach this area to come to here. So this is long, and the left side is light. So always remember, the role of the flap is assistant of direct closure. So we have to design the flap in the direction of direct closure, okay? So next one is transposition flap. So this is radiation ulcers. So remove not only subcutaneous tissue, but also necrotized muscle. And flap is designed adjacent to the recipient side. And this flap is come here 1 year after surgery and 5 years after surgery. Okay, so please remember that when you cut the flap, you can realize this flap, another flap is made. This flap is flap A, and this is flap B. Flap B is coming out. when we start to cut the flap A. And this flap A and flap B is transposed. This is the very important things for transposition flap, because little by little A and B is transposed, and if each flap leads to the, for example, flap A leads to the recipient side and flap B leads to the donor side of the flap, we stop to undermine. It is safe procedure, okay? So in this case, this is bursitis, so remove bursitis completely. And of course, island flap you can design, but skin pedicle flap is, if you can keep, skin pedicle should be keep to release tension after surgery. And in case of axilla contracture, so contracture area is cut and released contracture, and this flap is coming to recipient side, but you can realize this becomes flap B. So flap B, when we confirm flap B leads to the here and flap A leads to here, we stop undermining. This is completely scarred flap. So congestion sometimes will be problem, but this case completely the contracture is released and survived completely 1 year after surgery. Okay, so in case of transposition flap, important things is how to decide the length of incision. At first, we start surgery with design of like this, but I mentioned when we start to harvest flap A, flap B is made. So flap A and B is transposed. This is true meaning of transposition flap. Okay, so for example, this we design very long flap, but flap A and flap B we can try to transpose little by little, and when the flap A leads to here, flap B sometimes always we have to simultaneously we confirm flap B also leads to here, and we stop undermining. So skin is cut, but undermining area is just like here, I think. So quite safe. So, but sometimes, so younger plastic surgeon harvest transposition flap completely at first, and strongly with strong force, this area is sutured here. So if so, distal area will be necrotized, and there's at least congestion occur. So when we stop, always we have to think when we can stop undermining of flap. Okay, so if so, flap B, you have to recognize always. If so, such kind of long flap survived completely. So almost there are no congestion 2 weeks after surgery and no necrosis, okay? And 2 months after surgery, 10 months after surgery, the around 7 to 10 centimeter of contracture is released completely. So skin pedicled flap can release contracture effectively. So please remember. So always island flap, skin pedicled flap is better than island flap. So contracture exists here, just contracture is cut and interposed skin pedicle. The skin pedicle, after surgery, skin pedicle can release tension effectively. But if you do this surgery using island flap cannot release tension effectively compared to skin pedicle. So if you design skin pedicle, it is clearly better, always. next, if it doesn't, the flap doesn't move to the recipient side, we have to change to island flap. So this is elbow joint. I'm sorry, knee joint, the back side of knee. So thicker part, just thicker part is removed, and flap A and flap B is transposed. Flap B reaches to here, we stop undermining, and the distal area can survive completely, 1 year after surgery, 2 years. This is keloid, and this patient cannot move left shoulder. So cut this area, and large transposition flap is moved to here. And this keloid is removed. And after this is 6 months after surgery and 2 years after surgery, the completely ROM improved. And of course, radiotherapy we perform in this case. But the local flap is very important for such kind of contracture. Also, keloid reconstruction, it is important. So this is mature scar, burned scar, but contracture sensation, see complaint about. So relatively healthy skin, on the healthy skin, we design the long skin pedicled flap. And flap B and flap, this is flap A and flap B and flap A, okay, and transpose. And 1 year after. So chest wall keloid. The skin pedicle, if you can remain, it is clear better. And the flap should have deep fascia. It is important because deep fascia should be sutured. So this deep fascia of the flap and deep fascia of pectoralis major should be sutured. So the tension can be removed, tension can be released. Tension of dermis can be released. Okay, keloid is repeatedly, I say, the keloid hypertrophic scar is chronic inflammation of the dermis, and the tension make inflammation worse. So tension of the dermis should be released. If so, we have to go deeper, and deeper tissue should be sutured. Okay, so deep tissues, this flap should have strong structure. So fascia should be included. Another advantage of fascial flap is blood flow. The fascia of blood flow is horizontally and very strong, so safer flap can be harvested. But disadvantage is sometimes becomes thick. So in this case, we can thinner, but in this case, the same thickness we can harvest, and because the donor site and recipient site is close, so fascial flap is better. So fascial flap is harvested and suture with pectoralis major deep fascia and post-op radiotherapy. So similar case, for safe, that we detected perforator here using MDCT and intraoperatively confirm, but we don't need to make skeletal lines. Just we confirm this is safe. And move here and suture, and 6 months after suture. So in case of neck, contracture direction is vertically. But in case of chest wall, contracture direction is horizontal. So this meaning flap design, the direction of flap design should be 90-degree different. So in case of neck, contracture is this direction, tension is very high. So cut and flap is designed like this. So always flap should be designed vertically, okay? So if so, after surgery, skin pedicle is really can release tension effectively, So this case, large transposition flap is designed. And in this case, perforator is attached to the distal part. And the 4 centimeter length would be fine for supercharging. And the recipient side is removed, contractured area is removed. And facial artery and internal mammary artery perforator is anastomosed under microscope. And this is 3 months after surgery. This is skin pedicle. And 18 months after surgery. Look at this. So, the skin pedicle can release tension and the distal area completely survive. So the tension can be released by flap. Actually, this width is totally different from when we designed the flap because skin pedicle flap can release tension effectively. So healthy skin can release tension effectively. So this is advantage of flap compared to skin grafting. This case, the sky is removed. And the perforator, we could find 2. So the second perforator and the 7th internal mammary artery perforator. So both are attached when we harvest flap. And just one is used finally. And the facial artery and the internal mammary artery are sutured under microscope. And please look at this, 2 years after surgery, skin pedicle, the width of skin pedicle becomes quite longer. This means the skin pedicle can release tension effectively. So maybe you know bilobed flap. This is flap A and flap B is transposed actually. And flap C and flap D is transposed. So now you realize this is classified as a combined transposition flap. So bilobed flap is transposition flap. So Axilla, this is a pyoderma patient. So remove the pyoderma of axilla. And this small scapular flap is designed to close donor side, make easier to close donor side. And this parascapular flap should be designed longer because this distal area should reach to the anterior axillary side. And 1 year after surgery. This is keloid with multiple diabetic ulcer. So not so easy, but same situation, same flap can be designed. So parascapular and scapular combined flap. So actually this is propeller flap, island flap we have to design. The skin pedicle cannot remain. So this area leads to the anterior side, but still next to the flap, the contracture remains. So square flap we designed later I will talk. The square flap is designed. And finally, after second surgery, we perform radiotherapy. So 1 year after surgery. So maybe you know rhomboid flap. Rhomboid flap, there are 2 types of flap, Limberg flap. First type is Limberg flap. This is Limberg flap, diamond shape we cut and just moved to here, 1 month after. I'm sorry, this is misspelling, but a deformental flap. Second one is deformental. The design like this and like this. This is Limberg, and this is deformental. So both are okay to design, but Limberg, in case of Limberg, flap A, maybe our image, flap A is rotated to here, rotate to cover the recipient side. But this side, this deformantile flap. Flap A and flap B is transposed. So in this meaning, if this angle becomes larger, meaning of rotation increase. But this angle decrease, the transposition, meaning of transposition increase. So in case of rhomboid flap, deformantile flap is similar to transposition flap. But of course, a part of meaning, the rotation meaning exists. But Limberg flap, rotation is stronger than transposition. Okay. So this is rhomboid flap, pig skin. So recipient side. So we design like this. We can design same lengths. This is very easy to design. So before surgery, please try to pinch the skin using your hand, using your finger, and please decide the area you design the flap. And subcutaneous tissue, at first, you suture. So again, important things is you stop undermining of the flap when the flap reaches to the recipient side. Okay, so Z-plasty, I'm sorry, this doesn't move, but Z-plasty is a transposition flap. Immediately after surgery, such kind of zigzag line shape is made. This flap and this flap is transposed. 3 months after surgery, you can realize horizontal scar, inflammation already gone. 6 months after surgery, 1 year after surgery, almost inflammation gone. This means the long scar is segmented, so tension decrease. So inflammation doesn't continue. So tension decrease, in the results, inflammation decrease. So hypertrophic scar will not be developed and maturation of scar is accelerated. Okay, so local flaps, now you can understand basically there are 3 types of movement of the local flap: advancement, rotation, transposition. So there are other type of flap. So propeller flap. Propeller flap is an island flap. So such kind of severe burn patient, relatively healthy skin can be used as a propeller flap to reconstruct, to release tension. So subcutaneous pedicle flap, the rotation angle, the 90-degree will be maximum, but propeller flap, perforator pedicled propeller flap, PPP flap, is a skeleton, can be, if we can skeletonize, it can rotate 180 degrees. So if there are 2 recipient sites, we can design the flap between the 2 recipient sites and just rotate and close donor side simultaneously. So this is central axis type, and this is eccentric axis type. In this case, contracture exists here, and the skin ulcer exists here. So between these 2 regions, we design propeller flap and rotate. And post-operative radiotherapy is performed. This case is also skin pedicle flap we couldn't design because the skin pedicle is very limited. Remaining skin area is very limited. So propeller flap is designed. And post-operative radiation was performed. So this is flap. And this is reverse shore flap. Vascular flap is also propeller flap. 3 years after surgery. So pectoralis major flap is sometimes can be used for chronic ulcer of chest wall. So flap is designed. This is the pectoralis major PM flap, but muscle pedicled propeller flap can be classified. So movement is, so can move to the distal area 1 year after surgery. So finally, please remember square flap method. This is actually transposition flap, a kind of transposition flap, but a combination of square flap and triangular flaps. This triangle flap comes here, and this triangular flaps comes here. So extension rate is over 2.5. So after surgery, each skin pedicle can release tension effectively. So finally, that extension rate becomes 3 to 4 times. So initial Limberg original method is double 30-degree flaps is designed. So this is 30 degree, and this length and this length is same. So it doesn't come here, and comes here, and this also this length and this length is same. So like this, a little bit different from our square flap method, but this is immediately after surgery. This is square flap method. The thick part is removed, and between thick part, over the thick part, the square flap is designed, and triangular flap is designed like this. And this flaps comes here, and this the flaps comes here, this flaps comes here. So double transposition flap. Immediately after surgery, the shape of square flap is square, but 1 year after surgery, the shape becomes triangle. This means skin pedicle can release tension. Okay. So not only advanced, but also this square flap go down and make depressed area. So square flap method is good for such kind of web and axilla and cubital fossa, and 3-dimensional reconstruction can be effectively performed by square flap. So there are contracture and double transposition were performed. And please look at this, 18 months after surgery, was shape that maybe length of square it becomes twice. Very effectively, this skin is extended. So this is bilaterally the back side and the anterior side. We designed 2 square flap method and 2 years after surgery. So this contracture, mature scar contracture, is also reconstructed by transposition flap and square flap 2 years after surgery. So another very interesting flap is a Readingman flap. This was reported by Mutaf. So shape is looks like a reading man, the man reading book. But actually, sometimes the tension becomes stronger, so sometimes difficult to perform. But this is also the combination of transposition flap. This is 18 months after surgery. So my talk is finished, but actually this is whole world is a COVID, a very difficult situation, but we always welcome visitors from all over the world. So if you are interested in our plastic surgery department, our surgery and the scar management, so please come Tokyo and let's discuss about plastic surgery and scar management. So please contact me. And if you are interested in such method, mainly I'm doing bone reconstruction and scar management. So textbook is focusing on bone reconstruction and scar management, but if you are interested in, please look at these textbooks. So thank you very much. If you have any questions, I can take.
Thank you, Professor. Very wonderful, amazing, and comprehensive talk. If there are any audience, any question from the audience?
Professor, I have one question about the transposition flap. You mentioned the flap A and the flap B, so you should to cut, and then you will to reach when you reach this side, and you will doing the undermine from the flap A just to transposition, and then you can softly to code you directly.
Yes, also flap B should be undermined. And if we do undermining of flap B, it is much more easier to transpose. So flap A, not only flap A, but also flap B should be undermined. Both undermined. And little by little, the chain transpose, try to transpose and conclude surgery. It is very important.
Okay. Thank you very much. Is any question from the audience?
Yes, this is Dr. Lai from Kaohsiung Chang'e Memorial Hospital.
Yes.
I thank you, Dr. Ogawa, very wonderful presentation and gave us a very sophisticated thinking process of the local flap. I think for the such a long skin pedicle flap, we always worry about the distal circulation, and I think your technique is use the enough subcutaneous pedicle to provide a better blood supply. Am I right?
Yes, of course. So if you can, so subcutaneous skin, so it depends on the blood flow. Blood flow, it depends on the undermining, when we stop undermine. And of course, subcutaneous pedicle, the subcutaneous tissue can be keep, the blood flow becomes stronger. But skin pedicle, if we can keep, the venous drainage becomes very strong. So as much as we can, we have to keep skin pedicle. But if it is difficult, so we have to design island flap. And the island flap, in case of island flap, blood flow is coming from only subcutaneous pedicle. But venous drainage becomes very difficult because blood flow coming from deep tissues and coming to the skin, but these blood flow come back to the deep tissues, so it becomes congestion. So skin pedicle is always better than island flap.
Thank you. Yeah, thank you for your answer. So in your concept, the width to length ratio, 1:2 or 1:3, it doesn't mean anything, right?
Yes, I think so. Yeah, you're right.
Okay.
1:2 is quite safe. But of course, over 1:3, 1:4, sometimes we can design. It depends on the technique.
Okay, thank you. Thank you very much. A wonderful presentation. Thank you.
Okay, thank you, Dr. Lai, and thank you, Professor Ogawa. Is there any other questions?
Dr. Pan from National Cheng Kung University Hospital. So my question is similar to Dr. Lai. So how about a post-operative medication for your local flap. It's very important for using post-operative medication to improve flap circulation. It's very important.
Yes, so if the flap tends to congestion, the compression is very important. Compression and the moisturization using maybe antibiotics ointment. But I don't use steroid because the steroid can decrease blood flow in a short time. So I think if the flap becomes congestion, I use just ointment, antibiotics ointment, and a little bit compression we do. And sometimes the flap becomes black color. Maybe we inject the heparin, and blood flow, blood is coming out from the flap. But always, please try just moisturization using antibiotic ointment would be fine, I think. Is it okay?
The answer is okay.
Thank you to Rei Ogawa.
So is there any question from the audience?
Professor Ogawa, I'm the fourth-year resident Yang Junan from Keelung Changgen, and I have one question. Thank you about first. Thank you for your wonderful talk. And my question is: do you apply the negative pressure wound therapy in case of large flaps?
Yes. Yeah, I think it's a good idea because if we apply negative pressure, the blood flow can be removed from the margin of flap. So it is very good. And also the little bit compression force is applied. So congestion will be decreased, I think. So it is better if you can use negative pressure therapy.
Thank you, Professor.
Yes.
Is there any question from the audience? Okay, so let's close the lecture, and we will very thanks Professor Ogawa gave us such an educational lecture about the principle of the local flaps. Thank you very much.
Okay, thank you, Dr. Tsai.
Thank you,
Thanks.
Professor. Thank you for your time. Thank you.
See you. Bye-bye.
Bye.
Bye-bye. Bye-bye.